Hello, everyone. Today we have the privilege of hosting a renowned expert in trauma care. Please welcome Dr. Louis Dalutz. Dr. Dalutz is a trauma surgeon at Sunnybrook Hospital and a passionate advocate for advancing trauma care through research, education, and innovation. He's a clinical scientist and an associate professor in the Department of Surgery at the University of Toronto. He's also has been recognized as a distinguished teacher. He is here today to delve into some pressing issues facing paramedics in the field. In this episode, be prepared to listen to the latest evidence of TXA administration, explore the nuances of permissive hypotension, and discuss how these concepts translate into life-saving interventions for trauma patients. You'll learn that and much more. Dr. Louis Dalutz and I discussed numerous topics, but we made this podcast just specifically about trauma care and how it relates to the new medical directives. We hope you enjoy these subsequent episodes. So, what do you recommend? Should paramedics wait to do an IV or an IO or just give it by the intramuscular route?
I would say, you have your directives for the indication of giving TXA. And, if you have that directive, if you reach that point, or is it what? Low blood pressure or low blood pressure together with a suspicion of bleeding, right? In the torso, in the chest cavity, abdomen, pelvic, or long bones. If you're having a difficulty in getting the IV, and it's, again, you guys are very good in getting an IV. Sometimes, maybe it's difficult for all of us. If it's taking too long, go ahead and give, right? There are studies that show that bioavailability of the drug, IV compared with IM, is very similar. That's why we are expanding from giving IV to give IM and IO.
Yeah, that aligns with our teaching. Is give it as soon as you can because it will save lives. If paramedics did an IO, do you have a preferential site that you would prefer? Would it be the humerus? Would it be the tibia, just based on absorption of drugs and fluid, or does it matter?
For resuscitation, IO is good. Yeah. So we know that is good for everything. But the humeral, you're able to infuse more volume, like faster. This is what the literature shows. At Sunnybrook, our default is pre-tibial, because usually these patients, if you're inserting IO, in that environment, it's because lots of things are happening in the very, very head of the patient, right? So patient is being intubated, maybe there's a bilateral chest tube insertion, so there's not too much space there. The case of yesterday, we inserted bilateral pre-tibial IOs. The patient came already with an IV, but we knew that we would need to be infusing, drugs, adrenaline and blood products. Then we moved for a subclavian, a central line. When things were more, let's say, stable and the blood pressure was better, then we moved for, a central line. I would say that, and I think it is the easiest, right? The pre-tibial would be the preferred.
And if someone's on like Coumadin or Xarelto or any anticoagulant, does that inhibit TXA's ability to promote clotting?
It's not that I know, because, there's more research about the anti-inflammatory aspects of TXA. There's other things that it goes through the inflammatory pathway that it may help with the coagulopathy of trauma, because it's not only fibrinolysis. There's a bunch of other things that happen in the trauma coagulopathy. The TXA is really, the main effect is the antifibrinolytic. As far as I know, there's no interaction there.
And pelvic binders. What do you think about pre-hospital providers putting on pelvic binders?
I think it's important. What I would say, and if you go to a TLS, if your patient is hypotensive, you have a suspicion of pelvic fracture, and you have, I guess the idea would be this three. So hypotension, unstable on examination, your pelvis, and a suspicion of pelvic fracture. The intention there is basically to make things more stable, and if you have an open book pelvic fracture, to reduce the ring. If you have an undisplaced femur fracture, if you reduce it, the pain improves, the perfusion improves, and the amount of bleeding improves. This is then right. It's the same thing with pelvic fracture. What I would say is, when you are applying it, you have to think that you want to make things stable there. First, if there is open book pelvic fracture, you want to reduce. If you have unstable, horizontal or vertical instability, the binder is going to help you, make things more stable. This is going to decrease, the bleeding there. Imagine that, the great trochanter is the level where you're placing your binder. That if you tighten too much, there's possibility that the femur goes inside the pelvis. But if you do the thing with the intention of stabilizing it, then I would say it's okay. Again, it's difficult. Even in the trauma bay, people get very enthusiastic and tight, the binder. You have to be careful. Of course, we have the resources to look at the X-ray and say, let's be careful here with the binder. I guess I'm kind of talking too much here, but if you have a suspicion, go ahead, insert. When you are inserting, just be careful, because you have to think, if this is broken, if I'm tightening too much, I can cause more problems. I don't know, what is your orientation there?
I love that you said that, because to be honest, it lives in our basic life support standards and it's pretty vague, but we've done a ton of training on it recently because, correct me if I'm wrong, like 40 to 50% of pelvic binders are applied incorrectly in the pre-hospital setting. A lot of the time it was an at the greater trochanters. And this past CME we're actually getting paramedics to put it on to see that it doesn't take a lot of pressure to actually close the pelvis and stabilize it. And everyone's quite surprised because they felt like they'd have to crank it so tight. And we discussed how that can be problematic. And that bridges into, do you think they should use like a commercial pelvic binder device or a pelvic sheet wrap?
I would say commercial one, because, it kind of distributes the force in a higher area. The gold standard for management of pelvic fracture that is bleeding is angioembolization. For you to angioembolize, you have to put a catheter in the femoral artery. That big binder, you cannot keep that. So you have to cut it around because it covers the femoral artery. Right? So it's a problem. When you leave the trauma bay and take the patient to the IR, if you have a binder occluding the inguinal area, they cannot do anything. So before doing the procedure, meaning the patient is bleeding, you have to open the binder.
And we are getting ketamine for analgesia in the new year.
Nice.
And they removed our blood pressure parameter for fentanyl for our analgesic medical directive. What do you think about fentanyl and ketamine for analgesia for trauma?
So there was a minimum, there was a threshold for you to administer fentanyl?
Yeah, they
blood pressure wise?
Currently, or until the new directives go live, our blood pressure parameter had to be 100 or greater for systolic. But correct me if I'm wrong, at the dosages we give, 25 to 75 mics for an adult, and if we do aliquots, it doesn't really lead to vasogenic effects. And that's why it's beneficial for trauma.
I think in general, not only, pressure-wise, let's say talking, for the elderly, the effects are more, let's say, more pronounced. I've given, for example, 5 milligrams of ketamine or 10 milligrams of ketamine for, someone with 85 or 90 years of age. And it did the work there. We were reducing a wrist fracture, for example. So, of course, age is an important factor there. My experience, and again, it's, I guess, not only mine, but it's a kind of trauma bay in the TTL group. We use fentanyl quite a bit there. Ketamine gives you, the low dose gives you the analgesic effect. If you have to give just analgesia for something simpler, I guess if the level of pain is not too high, I would stick with fentanyl. I know that you have a limit of 20 milligrams, right? Is it
for IV?
Right?
Yeah, for IV.
Yeah, for per dose or maximum?
Yeah, so for adults, we can give 20 milligrams IV, 2 dosages, 15 minutes, and intranasal, 75 milligrams, 2 dosages again.
Yeah, you're fancy having intranasal.
Yeah. And like you were saying, ketamine can increase their blood pressure, right? From the release of epi and norepi.
Yeah. For all patients, or the majority, at least with the tachycardia, a little hypertension, that's going to happen. Anesthesia, for example, they always say, give a little fentanyl to oppose the effect of ketamine. But again, this is usually a more controlled environment, right? You have, respiratory therapies and there's more resources there. you kind of can play a little bit more with those drugs. Like, for example, what is your directives? So let's say if in the ambulance you give your 20 of ketamine, the patient starts to get agitated. What is your next step there?
Yeah, so the recommendation is to, like, if they go into that emergence phenomenon, is to patch for midazolam for like sedation or yes,
Yeah.
midazolam is the option.
Yeah.
Yeah. Have you seen the side effects commonly happen?
Oh, yeah. I was talking to Morgan because, he's an emergency physician. I just do trauma. I work in a luxury environment where I've never seen that airway obstruction, right? Production of secretion. I've seen it a few times. But the agitation, I've seen, I don't know, 5 to 10 times. And then the it helps.
Is there a way to mitigate the side effects? Like with a slow push or putting it in a 50 cc bag?
Yeah. I think in your directives that you have to have, is it 2 minutes?
2 to 3 minutes. Yeah, 2 to 3 minutes.
I'm going to confess to you, we do in 5 seconds. If you're pushing quickly there, for, respiratory arrest, there's more probability for that.
Yeah. And last question. What do you think of permissive hypotension for trauma?
Yeah. So permissive hypotension, so we learned everything that is related with bleeding and coagulopathy. Trauma comes from the military setting. Not everything, but quite a bit of things. And unfortunately, it's doing more. The concept came from them because you know how that happened. So they basically are in the field, and then they have a soldier hypotensive that they need to transfer to helicopter. They need to come and transfer to another hospital, and it takes 1 hour. They noticed that patients being hypotensive, they would have the same outcome compared with other patients who had the opportunity to be resuscitated. But this was validated, and nowadays it's in a penetrating mechanism. But we extrapolated to a blunt mechanism, meaning to the civilian setting. So in blunt mechanism, maybe a little bit of questioning there. In penetrating mechanism, for sure. It has its limitations. If you go to the literature, more than 30 minutes of ongoing low blood pressure, the probability that the patient is going to develop multi-organ failure later in the ICU increases. So you have to be careful there. So permissive hypotension is a temporizing maneuver. It's obvious, but you have to be careful. So ideally, you do permissive hypotension in let's say, just prior to go to the definitive management. Let's say in the trauma bay, I'm resuscitating the patient. I call the OR. They say, it's going to take 30 minutes. I can do a little hypotension there because I know that in 30 minutes, I'm going to be able to open the belly and stop the bleeding. I cannot do permissive hypotension for an hour. It's not adequate because then you're going to start to cause ischemia in the organs. So this is kind of the concept. In your environment, I think it's even more complicated because you only have crystalloids. I guess if you get that from the whole concept, if the patient is hypotensive because of bleeding, and in trauma until proven otherwise they are bleeding, you have to avoid to give crystalloids. But if you're in a pre-hospital setting and the only thing you have, and the blood pressure is 60, I'm going to give. So you're going to give some crystalloids there. So it's a little tricky. I'm kind of extrapolating because I guess I have a little experience, and the place where I work is it's a luxury place. I have everything there, so you can pay attention to these details. But I would say in the pre-hospital setting, if you have more than 90, I'm okay. I would be okay as a doctor. Less than 90, I'm gonna be worried. I'll be giving something, whatever I have there. Especially because you don't have the resources. Don't have fast. You cannot do a pelvic X-ray or a chest X-ray. So do you have any new directives for that or no?
We've been educating on it, that exactly what you said. Like, we want to restore enough blood flow to perfuse your vital organs. So correct me if we should be teaching a different number, but we've been saying 65. But we don't want to give a grotesque amount of fluid just because we know that could lead to negative outcomes. But if you leave them hypotensive, like you said, that leads to collateral damage as well.
Yeah, 65 is what, MAP?
Yeah, the MAP, yeah.
So see, map of 65 it's our map, right? It's gonna be like 110/70. Back can be used too, right? But you guys don't talk about systolic.
We do,
We
yeah.
always,
Yeah, we do. We just
right?
added the map in too.
Yeah. So the systolic that you would be aiming would be what? Or
Our directives say we should give them a fluid bolus to normal tension, so 100. But
yeah.
I believe we give the choice of paramedic to say if their systolic blood pressure is 96 and they look like their color's perfusing, they have a good mental status, and it's just like you can consider withholding further fluids at that point.
I love that. If it's close to 90, 88, then I'm okay. If it starts to go less than 85, then you get worried. All the information is important. So mental status of the patient, and also anatomically, if you're seeing that, there is a huge wound here, and there's a huge hematoma in the leg, and so you may say it's 88. I'm not able to control this. It's just partially controlled. I may give a little bit more because it's gonna go down. For sure, it's going to go down. So yeah, it's difficult. Yeah, again, for you guys, it's even more difficult.
I think that's a good spot to end it. Yeah, thank you so much for everything.
No problem.